Yes, I would like to request Ms. Mira Sepathy and also Director Joshi come to the stage.
We humans, in our arrogance, we think that we are the owner of this planet. That is not true. This is a ecosystem, it has a symbiotic relationship. So everything, our health, our nutrition also related to the health and nutrition of our, other species and everybody. So this is one point. Second point, little bit what kind of lifestyle we are now adopting and why the mission life is there. I would like to say, for example, food. Like we are very serious about health, food, water, fashion, these few things. So I will give you some data. As far as food concerns, nowadays we don't worry about food because my son, who is studying in class 10, at the night at 11 o'clock, he asked me, since he is preparing for some engineering, admission examination. So I have to worry about him, So at 11 o'clock night, he asked me to, Papa, I need pizzas. If the same question I would have asked my father, there would have been a tight slap and my father would have asked that 9 o'clock you should go to bed, 11 o'clock what are you doing, But I am a father, more liberalized, aware father. So what I do, I pick up my cell phone and I order Zomato or some app I use, and somebody at 12 o'clock midnight comes with a big packet. Lot many things, wrapping material, plastic and other things, and a small pizza. So my son eats, and morning, then it depends on him when he wants to wake up. But what I'm telling you, in only 2019 data is that in China alone, 9 million tons of packaging materials were used by them, which is equivalent to 700 million trees. Same, in our times, I belong to a rural place. My mother or parents, they were illiterate. But whatever used to come to households, they never used to throw it. They used to reuse it. Including newspapers, they used to keep it. If not sell, then they used to make small, envelopes or some kind of things to distribute prasadam or small kind of eatables there. But we educated ones, we forgot that. So in this world today, 74 kilograms of food is wasted by per capita waste is there. And if we put them on the trucks, then those trucks per year can, encircle this earth 7 times. So this much food is wasted. And plastic bottles, 20,000 plastic bottles are produced daily and 60 bottles per capita we are consuming, and what happens to those plastics we don't know. These all things, when I give you data that how much plastic is there, scientists say that roughly 80,000 to 120,000 those small nanoparticles of plastics are found in human beings, even in the placenta, stool of young born babies, these all things. So these all are correlated things, they are not isolated things. Finally, air conditioning. In Saudi Arab, 700,000 barrels of oil they just use for air conditioning. It's roughly 60% of their total oil consumption. And in this world, there is a calculation that by 2050, we will be having 9 billion air conditioners. That means every human being will be having one. And how much impact, these all 1.5 degree, 2 degree, these all talks in. Finally, fashion, whenever I talk to people, I ask, we like clothes, especially, women. And in India, even my wife, she has 30, 40, 50 saris at home. So many nice clothes, and those poor clothes, they hardly get a chance in 2 years, 3 years, but we keep them. There was a study in Britain only that in British cupboards or those closets, roughly 50 billion US dollar clothes are there which were never used. And same thing, per minute or per second, every truck goes either to incinerators or to dump yards of not used or, torn clothes. These all things, these all are impacting our earth. And one way or other, you believe or not, it impacts our health, mental, physical, everything. So, Prime Minister of India in COP27, he just, asked people why we cannot little bit tweak our lifestyle. Cannot we keep our air conditioners at 24 degrees Celsius instead of 17 and then using a heavy quilt? Cannot we use escalators, public transport, simple things so that we can save our planet? Because I think, now not only small little nags in the body, but our own survival is at stake. So we should all has to think and think holistically. Thank you very much for, Sukarya inviting me here and giving me this opportunity to. Just my one request is that if we, in all our these seminars, we can invite people from other walks of people, can allow them to understand these issues and how their, subject matter affects these all things. That will be a great thing. Thank you very much for listening me so patiently. Thank you.
And this session was specifically designed with a lot of research, even a lot of homework. And breakthrough research are happening in nutrition sector. So we thought that why not to start a session and bring eminent persons and personalities who can also share their insights.
Current challenge, besides anemia remaining largely weak, implementation remaining weak, we have a problem which we have recognized today. It's not only limited to women who are attending public health or in the poorer section. It's a universal problem in our country. Universal severe public health problem is anemia. We must recognize this. This is what I'm stressing on. And we have to reach the unreached public health system plus higher wealth groups and masses. AMB is limited to public health system context and it is only free supply. Should we depend only on that? We are only reaching government schools. Guidelines on how to improve coverage of, as I mentioned, of 20 to 24 years and 25 to 45 years is rather vague. ANC platform is the one platform where maybe the private sector is also participating in prescribing IFA, but we have to make an active effort to make sure even in private sector, private practitioners are prescribing it as a part of ANC treatment package. So I would repeat that it's a universal problem. What can we do? We need a two-pronged approach. One, we need reaching through government health education ICDS systems, free supply with intensive education and counseling. And the second is priced IFA. Social marketing of IFA tablets is something we need to consider in the private clinics of ANC services, in private schools, and in women in reproductive age who are in the university, employed in factories, tea, textiles, etc. In fact, when I did a study in tea gardens of Assam, I found 100% anemia in adolescent girls. So we can't really ignore them. And women cooperatives, we have youth groups, we can reach them. We have to just make a little, we have to understand first of all and understand and agree that it is a universal problem. What is social marketing? Priced IFA supplements. It has to start with formative research, and we have to do the marketing principles of 4 Ps: product, price, place, and promotion. Evidence of good practices. We don't seem to now record good practices. I have been looking for good practices, and Akriti is here who has helped me a lot to track it. We don't find it in don't find good documentation of good practices. We have to invest in research, evaluation, documentation, and sharing information.
No. Perinatal anemia is one of the most important public health issues worldwide, with a global prevalence, as we just heard, of 30% among reproductive age women, and that increases to 36.5% globally in pregnant women. This is a significant impact on reproductive, maternal, neonatal, and child health. And I should say, I actually came to the world of anemia via psychology, via mental health. I'm actually trained as a public health psychologist. So I didn't start out with anemia. But looking at how they're related is something that we really do need to pay attention to, and especially, as we just heard, where we are today. This is the global prevalence of anemia in non-pregnant women, and you can see that this is a significant issue. When we look at a heat map of anemia in women, be it in pregnant women or in non-pregnant women, we can see that there is a dire need for attention. But like I said, I came to this via mental health. So perinatal mental health. We know that global estimates of mental health issues in pregnancy are between 10 and 30%. That is a huge range. Life-altering moments like pregnancy, birth, and early parenthood can be stressful for women and their partners. And as a result, women may undergo a period of poor mental health or witness a worsening of previous mental health conditions. Almost 1 in 5 women will experience a mental health condition during pregnancy or in the year after birth. Among women with perinatal mental health conditions, 20% will experience suicidal thoughts or undertake actions of self-harm, which means ignoring mental health not only risks women's overall health and well-being, but also impacts infants' physical and emotional development. We also we see a lack of social support around mental health issues. And especially we see cultural and social norms that perpetuate women's suffering. Maternal depression is highlighted as a global public health issue. Maternal depression in the perinatal period is linked to a wide range of adverse child outcomes, including compromised physical and cognitive development, behavioral difficulties that points to the common mental disorders such as depression, anxiety, and stress during pregnancy that confers a specific risk to the developing fetus and affecting later child development. And we can see the global prevalence of postpartum depression. This is where India and US are very similar. We have similar rates at about 22%. And this was, as you can see, this is pre-COVID. And we've actually seen after COVID that these rates are increasing by 15% or more. Our current perspectives, though, take anemia and postpartum depression separately, and we need to change that. We can see here some of the associations with anemia, be it with infant outcomes, maternal factors, and also our social and structural determinants of health. We can take these same associations for perinatal depression, and you can see that they're actually quite similar. And we can ask ourselves, does anemia lead to depression or does depression lead to anemia? We know that the physical symptoms of anemia, such as fatigue, weakness, and difficulty with daily activities, can contribute to feelings of sadness. And more directly, the lack of oxygen in the brain caused by anemia can affect how the brain functions and lead to mood disturbances and depression.
Okay. So for optimal growth and development, the baby should have a normal birth weight. They should receive exclusive breastfeeding for 6 months. They should be prevented from infection by timely immunization and hygienic practices. And they should also receive adequate care during and after illnesses. And if any of these fails, then these infants are at risk of growth failure. The WHO also in 2013 update, 2023 update, they have identified a separate group where they call infant at risk of poor growth and development, and why we need to identify and manage them. This is largely modeled on Miami Care Pathway, which is a global tool for identification developed by ENN. And we tried to use this for our country. So what is the first step is identifying infants who are having serious illness, which we do by using IMNCI, which we say, which our health worker, they usually identify. So we try to identify the infants who are very weak, the birth weight of less than 1.8 kg, and certain other high risk conditions which will need hospitalization. Then the second step is looking for their anthropometric measurement, and for this age group, even weight for age is a good anthropometric parameter to identify the infants at risk. So that is the second step. The third is to see whether the weight gain is adequate or not, and that we will know by comparing from the previous one, the previous visit. We try to analyze their growth curve, whether it is upgoing or not. And then step 3, we try to identify whether this baby was born low birth weight or this is a baby who was discharged from a special care newborn unit. The 4th is assessment of breastfeeding practices. We try to see attachment positioning, which our health worker, they are trained to do so, and try to correct that whenever there is problem. The last is assessment of maternal nutritional status, health and psychosocial status in identifying mother with adverse psychosocial problems. Using this, these measures, we classify them into 3 categories. If the infant is at severe risk of malnutrition due to the infant's own parameter or maternal, because we always take here infant and mother both as a diet, because the most of time the problems are interrelated. So then we have a pink classification who will need referral to a health facility for management. If the infant and mother diet, they have moderate risk, then they will be managed at community, but they will need more close monitoring and more attention for improving weight gain monitoring. And the infants who are not at risk, like if they have normal birth weight, they are growing well, the mother is not having any high risk, then they are classified not at risk and we give them a green classification. So just to summarize, if we are able to use every community and health service contact point for nutritionally assessing and appropriately supporting these infants and mother diet, this will not only help them to survive but thrive also. Thank you.
I've been working with partners in Kenya at the Kenya Medical Research Institute on how do we expand that community management and how do we enhance the prevention of wasting. So working with KEMRI, we devised a program to try to reach some of these children. We took a family MUAC approach. That's where you teach a mother or a father to use a mid-upper arm circumference tape. You give them 2 of them and you send them home and you tell them if you measure a yellow measurement or a red measurement on your mid-upper arm circumference tape of your child, you bring them back to clinic, we'll confirm the measurement and then we'll treat them. We added to that program a 2-way text messaging support. So every week we would message, usually the mother, saying we would have their name at the beginning of the message. We would give them some kind of health education, whether it be about psychosocial play with your child or about maternal health issues or about WASH perhaps. And then we would ask them, remind them to measure the MUAC and to return the measurement to us. Interestingly, in that program, we didn't give any nutritional education because we just wanted to know if you give the ability to monitor nutritional status in the home, how does that affect outcomes? We randomized 600 children to that, and then we had 600 children who were randomized to receiving a typical community health worker program where they get active case finding visits. So this is what we found, and actually these results are hot off the press. This was published, I think, on Tuesday last week. So this is the first public presentation of our results. What we found is that the mothers who were randomized to this family MUAC approach, their children had a 37% reduction in the incidence of wasting. So they were 37% less likely to become wasted, which is pretty substantial, particularly given that we weren't actually giving nutritional education as part of the program. We also found that children who did become wasted were far more likely to be identified in the family MUAC arm than they were in the standard of care arm. Our standard of care is actually still quite strong there. It's still stronger than most of the programs that were in the meta-analysis we were looking at earlier. So we're really excited about this result. So we wanted to dive into these families and do in-depth qualitative research of like what actually changed. What is the behavior change that allowing families to monitor their child's nutritional status, what did it engender? What we learned is that we had asked caregivers to measure the MUAC once per week. They were regularly doing it 3 to 4 times per week. Some mothers were doing it every day. That's probably a little bit excessive, but 3 to 4 times a week was happening a lot. And what we heard is that they felt very empowered. It really helped them understand and feel confident in what was happening with their child. And I'm sure many people here have personal experience that when you have a 6-month-old, 7-month-old baby, and they're partially breastfed, they're weaning onto family foods, it's very difficult, particularly if you're a first-time mother, to know that that child is actually receiving as much food as you want them to. So this intervention gave the mothers a lot of confidence. So in summary, we've got to expand the coverage of highly effective nutrition services. We were able to do this in Kenya, and that led to over 1/3 reduction in the prevalence of wasting. And it's time that we take a more advanced approach to international guidelines for pediatric care.
Designed an integrated solution. And when I say integrated here, it's basically a combination of health, education, and livelihoods intervention, all aimed at addressing the issue of undernutrition among children. We had 4 outcomes. The first was to significantly reduce the prevalence of wasting and underweight. And the other 3 was one on the education to ensure that most of the children are school ready, building mental health resilience skills among adolescents, and of course, how can we engage women and self-help groups in this cause, as well as increase their income levels. Today, I'm just going to focus on the first outcome that we have. So this is a 18-month project. We started out early this year, and we started out with a baseline study. We have a significant, the sample size of about 3,400 in the intervention and 3,400 in the control group. This project is being implemented in 3 states, Madhya Pradesh, Odisha, and Karnataka. And in each of these states, we are saturating an entire block, about 10,000 to 15,000 children. That's the target. So some surprises in the baseline. We found a higher level of stunting than the NFHS data that we have. I'm not sure if this is because due to COVID, because the NFHS was done probably 3 years back compared to this study. We found that the wasting levels were lower than the NFHS. I'm not sure if this is because of the higher stunting levels that we are seeing. There are studies that indicate that if stunting is high, that tends to, sort of make the wasting data murkier. So the underweight, of course, is about 1/3, let's say, and that's more or less similar to the NFHS data. So based on this, we have a set of interventions starting from the top and going clockwise. What we begin, or what we've started to do, is to ensure that growth monitoring happens consistently. There's another slide coming up which talks about what percentage of growth monitoring actually happens. And this is, the consistent growth monitoring is in fact very low. And based on the growth monitoring, once we identify undernourished child, then the focus shifts to home visits, where we engage with caregivers and family on counseling, on interpreting the growth chart.
We did try to do a deep dive into the national level surveys, NFHS 4 and 5, for specifically these 11 states that were the priority states for the bank in the Poshan Abhiyan. For some of the indicators like child stunting and nutritional status of women, dietary diversity scores and all. And what we see is that there were significant differences in the key nutrition indicators in these priority states. So we had 11. 7 out of these 11 priority states actually showed significant reduction in the stunting and the wasting levels in children under 5 years of age. While stunting we found got stagnant in states of AP, Gujarat, Karnataka and Maharashtra, and wasting got stagnant in Maharashtra and UP, rest, majority of the states, again, we could see the significant differences. While for women undernutrition levels, all these 11 priority states showed significant reduction. Again, as I said, we have been hearing about the multisectoral and the interdepartmental approaches that have to be looked at. This is the graph that shows that for changes in stunting, we need to look at the household conditions, maternal factors, and certain unexplained factors that also contributed to these changes. So what's emerging from these success stories? Our key points and our key learnings from this is that there are no magic bullets, right? We have to go hit and try and come back, share our learnings. But something that to keep out is that what we learned worked is not being scaled up. A classical example is now food fortification. We learned it worked, we have seen global studies, but still we are far from the scaling up of that intervention. So if something works, let's look at how that can be scaled up to bring about those transformational changes. Under what next slide, I just want to focus on this one, which is kind of a framework that we have been looking at for tackling. Of course, the high-level political commitment, continued high-level political commitment. We are fortunate that stays, that remains there. We could see that. Focus on interventions in first 1,000 days. Although there are emerging issues, but that and the strides that we have made, it needs to continue on that front. Probably look at the adolescent nutrition and the pregnant women more strategically, more focused manner. Improving coverage and the quality of the various interventions that are ongoing.
I will be talking about maternal health, approaches to close the gap. And my focus will essentially be around innovations and certain research gaps that we think in India we can implement and look at to improve the maternal health in India. India has made huge progress in the area of maternal mortality with almost a 70% decline over the last 2 decades. This improvement reflects strong political will, well thought of interventions and programs, access to affordable healthcare by the government, and the development partners. With the umbrella under Poshan Abhiyan, Supplementary Nutrition Scheme by ICDS, Anemia and Malnutrition, we have seen a consistent decline in the state of underweight for women in reproductive age group. However, if you can see on this graph, there are two bars which have been highlighted. One that of overweight, as Deepika was also talking about, and the other is anemia. And with anemia, I would also eventually talk about some micronutrient deficiencies which hamper the maternal health and maternal malnutrition in terms of the double burden. The rise in cases of obesity amongst pregnant women and increasing prevalence of anemia is on the rise. 1 in 2 women are found to be anemic. As mentioned previously, the government has taken various steps to address underweight and anemia. However, we require a comprehensive policy and a programmatic approach to curb the burden of malnutrition. So at Sight and Life, what we are really trying to do, we believe in bringing science to the table. So many plant-based food, such as cereal, legume, nuts, nuts, seeds contain high phytate level. Now, what is phytate? It is an anti-nutritional as it prevents absorption of mineral like calcium, zinc, iron, and hampers protein digestibility. So what we are trying to do is we are trying to introduce an enzyme called phytase in food products, which is an evidence-based solution which can, when added to food, increase quality and digestibility of plant protein, and the absorption of calcium, iron, zinc, and other minerals in our body also increases. It is a proven cost-effective intervention. It's climate-friendly nutrition intervention and also has a huge market. It's been historically used in the animal feed market. However, increasingly now there are lots of studies which have come out for it to be a proven intervention in the nutritional market for human interventions. It is easy to use, scientifically proven, safe, affordable. It also acts as a taste enhancer. So we are doing this project in India and in Nigeria. wherein in India we are trying to increase the phytase in condiments and also in fortified flour, which will eventually be used in bakeries for bread, for biscuits, etc. This is said to reduce iron deficiencies among women of reproductive health by 30%, and we are also looking at a 10 to 30% cost saving compared to fortification of flour with iron, zinc, and calcium respectively. In order to work on maternal health, I think stronger interventions are required to improve adolescent health. Investing in adolescent girls could be a game-changing intervention for better maternal health. Lastly, I would say that there is an increasing need to share knowledge and ensure better knowledge management. Recently, Saran Life along with Foxy, Figo and IEG, we have collated a very comprehensive resource on maternal nutrition health in India, but we have speakers, we have authors from across the world who have spoken about the importance of better interventions on maternal health.
I would request Professor Koirala to sum up very briefly about what we spoke and how it was during this session.
3-4 points are quite important. There are anemia prevailing still high in the nation and in our globe. There are hopes and we can correct those anemia prevalence if we consciously and focused intervention is done so that we can reduce those things. But there is no one single capsule to reduce all the things or eliminate all the things at a single point. Yes, definitely food system need to be cautiously monitored, and this food system approach is quite prominent for access, availability and utilization of food so that there is no scarcity of food, and it ultimately reduces anemia as we are talking about. And yes, definitely the life cycle approach should be consciously integrated in our whole system so that it will do definitely a very right thing to catch the group to reduce malnutrition.
Thank you so much, madam. I think the session was very insightful. I was thinking that should be more provocative, more argumentative, but it was very humble. Thank you so much to all our panel members, and thank you so much for bearing with us for more than 1 hour.
Thank you so much.